Assalamu alaikum. This presentation is on the single pedicle advancement flaps, one of the variants of local flaps in head and neck surgery. The planning for the advancement flaps is straightforward. You start with a defect somewhere in the face or the rest of the head and neck that cannot be closed primarily, and you want to mobilize local tissues, nearby tissues, in order to close that defect. And you figure out that you have more redundant skin laterally, and you want to mobilize this medially to fill up that rectangular defect. The flap itself is mobilized by cutting around it, usually two lines that are not necessarily parallel and the leading edge of the flap. But in doing this, you reduce the blood supply of the tissues that are going to be mobilized. Advancement flaps can be random or can be axial flaps. If it is random, it depends on its vascularity depends on perforators coming from the musculocutaneous arteries. The blood supply is significantly reduced by mobilizing this piece of tissue. And for that reason, the ratio between the base of the flap, through which the blood supply is now only coming, and the length of the flap should be considered carefully. In most areas in the body, this ratio is 1:1, like the breadth to the length. In the face, with its increased vascularity, you can afford to have a length of the flap that is probably about double the breadth of the flap, but that's just a very rough guide. If the flap is axial, that is, there are named cutaneous arteries supplying the skin of the flap, this ratio can extend up to 4:1 or even more, because you have the blood supply coming through the base through cutaneous arteries. The movement of the flap after mobilization to fill up the gap is linear, with no twisting or lateral turning. Advancement flaps are versatile in that they can be used to close up defects of various geometrical shapes. They can be used to fill up defects of the shape of a rectangle, a square, a circle, an elliptical shape, or even triangular defects. The design of and the planning of the flap will be modified in each of these situations, as we'll go through in this presentation. And the final outcome will also change according to the shape of the defect and the modification of the flap. So it can change from an O to an L shaped after the repair, or H after the repair of bipedical flaps, or an A can transform into a T if you are using advancement flaps from both sides to close up a triangular defect, and so on. Advancement flaps can be single-pedicled, or it can have two pedicles, bipedical advancement flaps, or even sometimes more than two pedicles. What we're going through in this presentation will be the single pedicle advancement flaps in its various forms. We'll start by going through the Burrow's triangles, which are essential in the planning of these types of flaps, and then we'll cover the O into an L advancement flap and the east to west advancement flap. One further example of advancement flaps, the V to Y flap, will be discussed in a later presentation. The advancement of the skin of the flap into the defect creates a discrepancy between the length of the flap itself and the length of the wound edge. And because the length of the wound edge is more than the length of the flap, and some redundancy of the tissues at the base of the flap is almost inevitable. And Excision of this redundant tissue would prevent the dog ear deformity, and that's the basis of the Burrow's triangles. The need to excise some tissues from the wound edge in order to flatten the wound after mobilization of the flap into the defect. The simplest form of these Burrow's triangles are equilateral full thickness skin and subcutaneous tissue triangles. The base of the defect and its sides are equal to half the length of the defect itself. If that's 2 centimeters, then you mark a 1 centimeter equilateral triangle on both sides of the flap, and that would prevent having a dog ear deformity in here. But that's just one form of Burrow's triangles. They come in other different forms, and there are other alternatives to it that will be discussed in a separate presentation. This is to illustrate the planning and the technique of the single pedicle advancement flap. You have here a rectangular defect that cannot be closed primarily, and you need to recruit local tissues to close this defect. There isn't enough skin above or below the defect or even medial to it, so we are going to utilize the skin lateral to the defect. You'd need to consider the relaxed skin tension lines because your incisions should be parallel to these lines. So you extend, because there isn't enough tissues above, below, or medial, you are going to take skin from lateral to the defect, and these lines are now planned parallel to the relaxed skin tension line. The lesion is removed and you are left with the defect now, and you have planned the flap so as to its length will be double its breadth, and you've also planned the Burrow's triangles at the base, two smaller triangles with equilateral triangles. The length of any of the sides of the triangle is half the length of the breadth of the defect. Now you can mobilize the flap to fill up the defect after undermining widely around the edges of the defect. Now, once the leading edge of the flap is in position and the Burrow's triangles are closed up, the defect is closed by a simple advancement of the flap to fill up the defect, and you have the lines of the incisions parallel to the relaxed skin tension lines. Defects can have various forms and various shapes. In this example, it's a circular defect lying below the lower eyelid and beside the nose. For this, the design of the flap will be modified in order to have incisions parallel to the relaxed skin tension lines. So you have the upper incision parallel to the lower eyelid and the lower incision parallel to the nasolabial fold. They are no longer parallel to each other, and you don't have to be parallel to each other. You have a wide base to supply the length of the flap after mobilization, and you can also consider where to have your Burrow's triangle in order to remove any excess or redundant tissue. And in this example, you can have the Burrow's triangle on the lower incision rather than the upper incision. So here is the circular defect, and this is the upper incision parallel to the lower eyelid and the lower incision parallel to the nasolabial fold, and then the lesion is removed. And the incisions are deepened in here so that you can mobilize the full thickness skin and subcutaneous tissues as well. And once the defect itself is excised together with its safety margin, then you can undermine the tissues around the defect, including the area of the flap, to ease its mobilization. In this particular example, you can deepen the incision beside the side of the nose down to the periosteum. Now you're changing the leading edge of the flap from concave to convex, and that would entail excising small triangular pieces of skin at the leading edge of the flap, so as to fit into the circular design of the defect. And then the flap is mobilized forward in a linear way, and you end up having closing up the incisions with the incisions line parallel to the relaxed skin tension lines below the eye and beside the nose. And this is another variant of the advancement flaps, the east-west advancement flap. It's used when you have a triangular defect created after removing a lesion, and if you try to close this defect primally, you will inevitably end up with a dog ear deformity towards the base, where you have excess tissues in here. The east-west advancement flap depends on creating another triangle with its apex in the opposite direction to the initial defect. That's why it's called east and west advancement flap. And removing this triangular piece of full thickness skin and subcutaneous tissue would ease the mobilization and the gliding of the tissues from lateral to medial to fill up the two triangles without tension and without excess tissue. So we have planned our incisions all to lie parallel to the relaxed skin tension lines, and now the skin incisions are deepened. The triangular piece of skin with the lesion in it is excised, and then the Burrow's triangle is created. And removed. This base is half the base of the defect. It's much smaller, and now you can mobilize the skin from lateral to medial easily, and the final closure would be parallel to the relaxed skin tension lines, and the side of the nose is here. One further indication for the use of single-pedicle advancement flap is for small lesions at the dorsum of the nose. An advancement flap with its pedicle superiorly is created in here. The lesion is then removed, and then the sides of the flap are incised, and the two triangular pieces of skin between the leading edge of the flap and the defect are removed, these two small pieces of skin, so as to have a convex leading edge of the flap that would fit in nicely into the defect. And of course you would need Burrow's triangles at the base of the flap as well. We've been through some variants of the single-pedicle advancement flap. In the next presentation we will go through the bipedicle advancement flaps. Assalamu alaikum.